specialist and has served for more than 30 years in Malaysian Ministry of Health. She is currently a visiting consultant pain specialist at Kuala Lumpur. Dr. Cardosa has done pioneering work in the field of pain management in Malaysia. This includes state-of-the-first acute pain service in the MOH in hospital in Kuala Lumpur in 1993. She also was one of the first who started first multidisciplinary pain clinic at MOH hospital in 2000 and has also helped in setting up the first inpatient palliative care unit in 2002. She is also responsible for implementing pain as fifth vital sign in 2008, and she was also was involved in the pain-free hospital initiative of MOH in 2011. Dr. Cardosa contributes to actively involved in teaching pain management in Malaysia and in Asian region. She was president of Malaysian Association for the Study of Pain for 10 years and now serves as advisor to MASP. She also served as council member in IASP for 6 years, followed by 2 years as IASP secretary, and she is currently the president of IASP. Please welcome Dr. Cardosa. She'll be talking about setting up interdisciplinary pain management services in limited resource setting.
Thank you very much. Thank you, and good morning again. It's not afternoon yet. So I will be speaking about setting up pain services in limited resource settings, and the type of pain service we want to aim for actually is interdisciplinary pain service, which offers a variety of services for a variety of pain conditions. So using a team of clinicians. Okay, so these are my disclosures. We have to start with disclosures, but I have no conflict of interest for this lecture. So I will, after just a brief introduction, I will talk about the burden of pain in low and middle income countries. So I'll be using these terms interchangeably: limited resource, low and middle income. Most of our low and middle income countries have limited resources, but as we were discussing at breakfast this morning, there are also low resource settings in high income countries. I won't be talking about that because I'm not from a high income country. But anyway, so I'll be talking about interdisciplinary pain management in low and middle income countries. What are the challenges we face? And then I will zoom in on our experience in Southeast Asia, how we promote interdisciplinary pain services, and mainly through pain education. I know that Dr. Claire Rhodes will be talking to you more about pain education, so I will be briefly skimming through a couple of the programs that we have in Southeast Asia, and I will focus more on the IASP Multidisciplinary Pain Center Toolkit project before some concluding remarks. So we all know that not all pain is the same. As mentioned earlier in the introduction of this conference, we have acute pain, which is pain due to injury and goes away when the tissues heal, and then we have chronic pain, which is a disease which is much more difficult. We also know that we should be looking at pain using a biopsychosocial framework as shown on the right-hand side of the slide, okay, where not just biological factors but psychological and social factors all influence a person's experience of pain and the impact of pain on that person's life. And yet, in many places in my country, including in Malaysia, many of us, pain doctors, as well as other clinicians who treat pain, continue to treat pain as acute pain, using more of a biomedical model without addressing all the other psychological and social factors that have to come together in the patient's experience of pain. So what's the burden of pain in our part of the world? Pain, we know, is common in low and middle income countries, and access to pain management is limited, very limited. More than 2/3 of people do not have access to good pain management. We have pain from cancer, HIV/AIDS, and trauma, of course, and surgery. And we also have a lot of chronic pain. Treatment is often inadequate, and even though we don't have a lot of data on the prevalence of chronic pain in LMICs, it is at least as high as in high-income countries where we have a lot of data from. So this is from the Global Burden of Disease, and this is accessible to everybody. What are the years lived with disability? Okay, if we look at the size of the colors, is the footprint, the size of the problem from those particular conditions. And you can see here that actually the global is on the left and low socio-demographic index, so LMICs, more or less equivalent to LMICs, on the right. And you can see that even though the footprint of the non-communicable diseases in blue is greater in the global overall, it's still very large in our low-income countries. And you have things like back pain, musculoskeletal pain, stroke, diabetes, which can all give rise to painful conditions. So we know that we have a burden. Looking at South Asia and the different, in terms of years lived with disability, the number one, the musculoskeletal diseases are either number 1 or number 2 burden of pain in these countries in your region. And in Pakistan, so you can filter the data down to the country level, and in Pakistan, musculoskeletal disorders have risen from number 3 to number 2 from 1990 to 2021. Okay, so we are an aging society, and we are aging faster, in fact, in LMICs compared to the high-income countries. And as our society ages, we know that the burden of pain will increase, especially of chronic pain. So what about, do we have interdisciplinary pain management in LMICs? Before I talk about that, I just want to go into some definitions. This is from the IASP website, terminology task force, and we have multimodal, which is a concurrent use of separate therapeutic interventions with different mechanisms of action within a discipline. And we do that in anesthesia all the time. So anesthetists are very familiar with multimodal treatments of anything, whether it's giving an anesthetic or giving pain treatment. Multidisciplinary is multimodal treatment provided by practitioners from different disciplines, but as you see, it's a very short definition. And what we are advocating is actually interdisciplinary management, which is multimodal treatment provided by a multidisciplinary team collaborating both in the assessment as well as in the treatment of a person with pain using a shared biopsychosocial model and goals. So it's multidisciplinary treatment, working together, talking to each other, collaborating. And I think that we use this term multidisciplinary very loosely, and we say we provide multidisciplinary treatment. But very often we are still working in our own silos. We really need to communicate with each other, and we need to communicate the same thing to our patients. So we have different types of personnel involved in multi or interdisciplinary pain management. The care is collaborative, and we must always remember that the patient and their family, whether it's people with acute pain, chronic pain, or cancer pain, the person and their family should be at the center of our care, and they are part of our team actually. Interdisciplinary pain management or multidisciplinary pain management, we often again use these terms interchangeably, but I would like to train myself to use interdisciplinary more, because that actually is, the collaborative model. It has a lot of benefits because assessment of pain is multidimensional, treatment is evidence-based, you have both pharmacological as well as non-pharmacological treatment options offered to patients. You avoid duplication, and you have consistent and coordinated care because you communicate with each other. There's lots of studies done on the evidence of the effectiveness of multidisciplinary or interdisciplinary pain management for chronic pain in general, chronic low back pain, osteoarthritis, and also there is evidence in cancer pain that it's better if you use a multidisciplinary approach in cancer pain as well as in acute pain management. So even though we as anesthetists are the main people who look after patients for post-op pain, for example, we do need the cooperation of surgeons. And, you know, I know it's a big struggle to get them involved, right? But when they are involved, as in Malaysia, we have this pain-free hospital initiative where we get people from all the different disciplines involved in the pain management, even in the acute situation. You have more effective pain management then. So this interdisciplinary pain management has been shown to be effective, as you saw, but implementing it in our settings actually face many challenges. Number one, the governments don't prioritize pain management. Why? Because pain doesn't kill patients. So they like to look at their data, they like to look at mortality data, they do look at morbidity data, but they are more concerned about mortality. So they are more interested in reducing prevalence and mortality from CMNND. This is communicable, maternal, and neonatal and nutritional diseases. Okay, despite the high disability burden of musculoskeletal diseases, as I showed you earlier in the global burden of disease data. The type of pain services in many of our countries is limited. So we have acute pain service, and sometimes it's isolated. Sometimes they ask you to see chronic pain, but anesthetist, I'm an anesthetist, I don't want to see chronic patients, you know. My colleagues will say that. Okay, so acute post-op pain, sometimes we only limit our service to cancer pain or palliative care. And sometimes we only offer interventional pain. So I noticed in your pain camps, for example, in Pakistan that you talked about just now, you're offering interventions to patients and drugs to patients, which is great. But at the same time, I believe that you also need to teach patients how to manage the pain themselves. Because what happens when you go? What happens when your pain camp is over? They are left alone. You are not there to look after them all the time. Okay, so limiting to one or two modalities, I think, is not the way to go for a good pain management service. There are lots of obstacles to good pain management. So we don't have policies on pain. We don't have country policies. So in Malaysia, we tried this through this pain-free hospital program to have a national policy on pain. And this is a big challenge, you know, and you need to work at it all the time, and you need to get buy-in from people from all the different disciplines. We have, of course, cultural beliefs and attitudes that, you know, if you have pain, you must be punishment from God, and therefore, you know, you shouldn't relieve the pain. Limited access to pain medicines, as was described earlier in one of the talks, and a bias towards biomedical or curative approaches. So we believe that all pain can be cured, and therefore we try to take away the pain by giving injections and using medications without recognizing, as was mentioned in your president of the Lahore chapter's speech this morning, that pain is a disease and cure is not an option, actually. Also, there are many challenges in setting up interdisciplinary pain management in our settings. Our colleagues, we are all trained when we go to medical school, nursing school, physiotherapy, whatever it is, we are trained in the acute pain model. We are trained in the biomedical model. And we don't have a lot of awareness about biopsychosocial. Everybody uses the word multidisciplinary, but do they really know what it really means? And do they really practice multidisciplinary pain management in a biopsychosocial framework? Additionally, there's lack of reimbursement. We are not paid to work in a team. We are paid to work as individuals. And therefore, there's no incentive for us to work as a team. There's no incentive for us to build our teams. So this is a big problem which I don't know who can address. And last but not least, we have always got to address the issue of limited resources. Not just people, not enough doctors, not enough nurses, but space. We don't have, we are fighting for rooms. We are seeing 2 or 3 patients in the same room in the outpatient clinic. We don't have enough equipment. We are using equipment that breaks down all the time. And all of us are exhausted from the heavy workload. So these are all the challenges that we face, and how do we overcome them? Just by being superhumans. So I will talk to you a little bit about our experience in Southeast Asia. Just a background. Southeast Asia, we started pain services in the 1980s, but this was mainly acute pain service, single discipline, limited services. Then in the 1990s, this continued to develop, but also not in a multidisciplinary way. Multidisciplinary services only started to develop after the year 2000, with a few of us who went overseas for training, coming back to set up multidisciplinary teams, okay? So I just listed them, and it's all listed in details in this paper by my friend Pong Paradi from Thailand, who was one of the pioneers in Thailand setting up multidisciplinary pain service in Siraj Hospital, which is now a training center for the pain fellowship run jointly by WFSA and IASP. So we recognize that the establishment of multidisciplinary pain centers as an integrated interdisciplinary services has been shown to be cost effective, especially for the management of patients with chronic pain, and it's an important step in improving pain management in our region. So some of the challenges faced, I already mentioned just now, but this was specifically for Southeast Asia: limited resources, heavy workload, not a priority, biopsychosocial understanding is not there, and the attraction of interventional procedures. So not only are interventional procedures more easily reimbursed, they're also very self-satisfying. I put in a blog, the patient says, I haven't had no pain for months or for years, doctor. This is the first time I have no pain in my back for years. Of course, that will happen because you have given a local anesthetic, right? But how long will it last? And what will the patient do with that opportunity of pain relief? It's a window of opportunity, I always say, which we have to educate the patient about how to use it most effectively. I'm not against giving interventions, but I think we should do it in the proper context. Okay, and we also have a very limited number of clinical psychologists who are a very important part of the pain, multidisciplinary pain team, okay? So, we managed to set up multidisciplinary pain clinics despite a lot of all the challenges that were listed just now, through commitment, through perseverance, persistence, and innovative ways of working. So you approach different people, you offer them, you attract people in different ways. There was support from clinicians from established multidisciplinary pain clinics in high-income countries. There was support also within, for us in the ASEAN region, the Southeast Asian region. We had this entity called ASEAN, and we were already friends. The anesthetists were all friends through the ASEAN Society of Anesthesiologists. So we all knew each other, and those of us who were setting up our multidisciplinary pain service, we actually supported each other through pain education activities, and also by listening to each other's woes. IASP was also very supportive. We had educational grants, we had visiting professors, and we have this fellowship that was set up in Siraj Hospital. We formed ASIAPS, the Association of Southeast Asian Pain Societies, as a way of bringing all the interested parties together, and ASIAPS is now a federation of the IASP, promoting interdisciplinary pain management. And I'll talk to you about the different education that education initiatives that we have set up, because education, or the lack of education, has been identified as the biggest barrier to good pain management, and therefore education is what we have to focus on. So what are the education programs that we have that I want to highlight? We have many, but these are the regional programs. the Bangkok International Pain Fellowship, which I mentioned, which trains 2 fellows every year. The university, and I think we have had people from Pakistan attend that fellowship. We have a Master's in Pain Medicine online course, which is the Sydney University one, but it's administered by the University of Santo Tomas, so we don't in Philippines, so we don't have to pay so much fees. EPM, of course, I'm sure Claire is going to talk more about it later. Essential pain management, and you have done this in Pakistan, and this was a very important step, I think, in promoting pain education at a very basic level to all healthcare professionals. Then in Southeast Asia, from 2011, we have been having this thing called the Southeast Asian Pain Camps, where we train a multidisciplinary group of young clinicians who are working in pain management. So you have the whole array of doctors and other and allied health professionals, and we had Dr. Gauha's nurse, is it, with us in Bangkok last year. Last but not least, which I'm going to talk a bit more about, is the IASP Multidisciplinary Pain Center Toolkit, which we started in 2017. So EPM I'm not going to talk about because Claire will talk about it later, but it is a system, and it's good for everybody to be on the same page and to understand about pain as a biopsychosocial phenomenon. The pain camps, this was something which I must give credit to Dr. Cynthia Gore from Singapore, a palliative care doctor who actually, together with Pong Paradi, a pain doctor, anesthetist and pain doctor from Thailand, set up the first pain management camp. It's a residential course. It covers essential elements in pain topics relevant to day-to-day clinical practice using a biopsychosocial framework. Okay? And we train a multidisciplinary group of clinicians. So in 10, 12 years, we trained about almost 200 people from 18 countries. Okay, but the toolkit is what I want to talk to you about. From our experience from the different training programs, we found that one of the challenges was we don't have clinical psychologists. We cannot use psychological approaches. We know that psychological approaches are very important in pain management, but we can't do it. So we came up with this toolkit to look at all the different people involved in interdisciplinary pain management, and to see how we could train everybody in all the different skills. So we really looked at multi-skilling rather than train the psychologist, train the physio, train the doctor, train the, so the doctors know how to put the needles and give the drugs. The physios know how to teach the exercise. The psychologists know how to teach relaxation. No, we didn't want that model. We wanted everybody to know how to do everything. Because you don't know who you have. You work. The idea is you work with who you have. Okay, so the vision and mission was to increase the capacity in delivering interdisciplinary pain management and to provide local clinical leaders with the skills, the knowledge, not just knowledge, but also skills necessary to be able to do this. So again, we had 3 target countries because this was a funded project by one of the Pfizer global grants for education and change. And the targets were Myanmar, Indonesia, and Vietnam, and we got them together with us as experts in the planning group to identify what the challenges. And the challenges were the same as what I mentioned just now, that we didn't have enough people, and we didn't have enough of certain types of people, especially clinical psychologists. So we came up with a manual, okay, with 5 chapters. Number 1, the need. How do you, because it's not priority, how do you make your governments or even just maybe your hospital administrator make this a priority? Number 2, who are the people you should get involved? Chapter 3 was on what are the services you can offer and what are the facilities you need. Number 4, how do you evaluate your service? How do you measure outcomes? And the 5th chapter gave 3 case studies from Philippines, Thailand, and Malaysia. So the first chapter is actually very important You know what is pain, who is affected by pain, and how do you make the case for multidisciplinary pain management. So you need to tell your bosses that pain is a biopsychosocial condition, phenomenon. It's not just biological. It should be assessed using this framework. It's an important cause of health burden to all of us. Effective treatment must use a multidisciplinary approach, which will reduce the burden on individuals and society. Using the right treatment for the right patients will lead to more appropriate use of limited health resources, and the right treatment can be delivered at relatively low cost. So, the other chapters, I don't have time to go into detail, but this book is available. You can see on the IASP website for everybody to download. And we are happy if you want to translate it into any different language. I think the people in Latin America have worked on translating it into Spanish. In the appendices, we have examples of, you know, different pain clinic layouts and, you know, very practical things that you can actually use. So I wanted to talk specifically about the training. We recommended different levels of training. So entry, intermediate, and advanced. And entry level is basically EPM. Intermediate level, I'll talk to you about in a minute. And advanced level is for the leaders of the pain clinics to maybe attach themselves and do graduate diplomas and so on and so forth, more advanced training. So the intermediate level training was what we carried out in 3 different countries in Southeast Asia. And the aim was multi-skilling for a multidisciplinary group of people, okay? On clinical assessment of pain, how to explain the differences. Sorry, can I take a couple more minutes? Case formulation, pharmacological as well as non-pharmacological pain management, and follow-up. And after we did the training, we had follow-up with these people. So I don't have time to go into this, but we had a list of core competencies, and we carried out the training in 3 different countries. One was in person, then after that we had to convert to virtual training because of the pandemic. I'm not going to go into this, but we had good outcomes, okay? And what was the impact? Impact of the training was a lot of interest was created. Several other pain education sessions have been organized. New clinics have been set up, or existing clinics transformed into more interdisciplinary clinics. Local champions, so people who are really pushing the agenda of interdisciplinary pain management. And we have plans to make this available to other countries. The manual is already available, and we are trying to get an online course going. So in terms of pain education, there's more demand for training on pain self-management. If you saw the core competencies, we actually teach people, how do you teach a patient relaxation? How do you teach a patient self-management skills like pacing, setting goals, and things like that? Okay, and we have a lot more activities, and we also have presented this at the World Congress of Pain in Toronto in 2022, and recently in Amsterdam in 2024. New services were set up, and I want to give you some examples in Indonesia and in Vietnam. So in Indonesia, we had this team set up by Dr. Jimmy Barros, who is a neurologist, and who really buys into the idea of interdisciplinary pain management. Okay, and as you can see, the members in that team is a variety, have a variety of anesthetists, rheumatologists, neurologists, neurosurgeon, physiotherapists, occupational therapists, pharmacists, nurse. Okay. In the National Brain Center, they already had a pain team, but they transformed this team into a more interdisciplinary approach, and they included clinical psychologists, nurse, and pharmacists, as well as physiotherapists in their team after the training. Da Nang is the star of the outcome of the training. This young lad called Dr. Quinn actually established his clinic in 2022, and it was the first multidisciplinary team in Vietnam. In Vietnam, the pain clinics were all needle clinics, you know, you give injections. And I don't have time to talk about that. But this guy alone mobilized other people in his hospital. In fact, he moved to a smaller hospital where the boss of anesthesia was very supportive of what he wanted to do. And he mobilized a team and he set up his clinic. Even in a small little room, you see this picture here. In the middle is a small little table and a computer that he had to start his clinic. He said, don't wait for a proper clinic, just do it in whatever place you have. He built up his team, and he has a lot of stories of how patients have improved because he takes this multidisciplinary approach and he uses a team approach in his clinic in Da Nang. So in conclusion, we all know that interdisciplinary pain services are important to improve outcomes in pain management, but there are many challenges faced by us in limited resource settings. However, we can do it if we have commitment, we have some enthusiasm, you have some what we call thick skin. Go and ask people to help you to do things, don't be too shy, okay? You start small, you build up your team, and you multi-skill. I think that's the most important keyword. Training and education are key, and you don't just have to train your own team, you have to train other people in the hospital as well to understand what you're doing. Okay, and we have built up this resource that we can all share to be able to have a better vision, better interdisciplinary pain services in the future. And this is one of my patients from an early pain management group who says, I still have pain, the pain has not gone away, but I can manage and it doesn't worry me. So that's what we really want to aim. They go back to normal life, they have normal mood. And I must end by thanking all the members of the team. As you can see, there's lots of people who are involved in this. I obviously did not do this alone. And I cannot name all of them, but they're from different countries, including from Southeast Asia as well as from Western developed countries. And thank you for your attention. And I end by inviting you to the 10th ASEAPS Congress in Singapore in May next year. Thank you very much for your attention. Apologies for overstepping my time.
Thank you so much, Dr. Cardosa.